All right. Our next speaker works right down the hall from me. Dr. Corey Falcon works at Ochsner, and he's going to be presenting on current and future therapies for rhabdomyosarcoma. Dr. Falcon.
Yeah, thanks a lot, Bob, for putting me after that great talk by Naveen. So I'm not an expert in rhabdomyosarcoma like he is in neuroblastoma. In our clinic, we do a lot of hematology and oncology, but since this is an oncology conference, and I've had several very difficult rhabdomyosarcoma patients recently that this was what I decided to talk about. And just talk about kind of historical perspectives and kind of some new exciting things that are happening with rhabdomyosarcoma. All right, so disclosures. Actually, what is it? Let me see. I'm trying to. It's like not coming up on the whole screen here. That's okay. All right. So a few disclosures. So for SOBI, I receive honoraria for advisory board and a speaker for HLH and Gamifant. And for Pfizer, honoraria for advisory board as well, and speaker for sickle cell and Oxbryta. All right. Oh, that's not, sorry. I don't know why it's not projecting from here. Okay. That's not. Bob, come see. Let's see. Well, no. Let's see. It yeah, it was like there's a couple. Let's see. So on this one, I still have the old one. Let's see from current slides. I don't know why it's not
in the slideshow.
Yeah.
That's weird.
Yeah, it's not moving.
That's really strange.
Okay.
We're having.
Should we go down there? Try
it. What's on the screen is not what's.
How many oncologists does it take to start it?
Let's get that guy from Google back here. Where is he?
Okay. Any experts here on this?
Because if it's doing with yours, it's going to do with mine.
Yeah.
Okay.
We're having.
What else is down here? Let's see.
Are there two of them open? Is that
Maybe. Oh, yeah. Okay. No? Sorry. All right. Thank y'all for coming. Yeah, there's several. Let's see. Let me try to delete. Okay. That was good. Let's see.
That's how it usually
Okay.
works.
But then now I can't see it on here.
There you go.
But
No.
it doesn't come on mine for some reason.
Let's see. I think this is the right one. Oh, but why is it not showing up?
Maybe it's that one?
Oh, yeah.
Okay.
Yes. And
Awesome. Great. Gosh. Thank y'all.
Yeah.
Perfect. All right. So what is rhabdomyosarcoma? So it's the most common soft tissue sarcoma of childhood. It's a high-grade neoplasm of skeletal myoblasts-like cells. And up to about 4 to 4.5% of patients, 4 to 4.5% of pediatric oncology patients have rhabdomyosarcoma. It is the most common, like I mentioned, most common soft tissue sarcoma. About 4.5 patients per million in the U.S., which is about 350 per year, so near the neuroblastoma. So very rare tumor that we see, but the male to female ratio is a little bit higher for males, and there's kind of throughout the age throughout childhood, but there's kind of a bimodal peak for one type that I'm going to talk about, early childhood and adolescence, but also we see lots of late adolescence, young adult patients, which typically have more unfavorable prognosis. There's about 50% of all patients that in pediatric and young adulthood, about 50% are less than 10 years of age. So a lot of the young patients, and around 20% of patients are metastatic at diagnosis, which the way you can have lymphatic spread and hematogenous spread as well. And the most common areas are to the lungs, bone, and bone marrow. All right, so clinical presentation can vary based on site, on the site of the location of the tumor. So, and often causes significant mass effect on nearby tissues. Can a lot of times be, sometimes be asymptomatic, but most of the time you will see that localized kind of compression or involvement to the local structures, like the orbit, which is kind of the poster child for rhabdomyosarcoma. A lot of proptosis, difficulty with eye movements, ptosis, and vision changes can be seen there. Perimeningeal, which is difficult, and there's a wide array of presentations. So you have nasal or sinus obstruction, seizures, cranial nerve palsies, encephalopathy, headaches, and then another common location is genitourinary, so hematuria, obstruction, constipation, and a lot of other symptoms in that area. And lastly, extremity oftentimes have functional impairment, pain, and even often visualize a tumor that you can see in those patients. So here are the World Health Organization subtypes from 2020. Yeah, this is my old presentation. That's okay. On the left, so with the pointer, nope. Yeah, so I'm going to talk about these two, the embryonal and alveolar, which are kind of archaic terms now, which I'll explain why. So the prevalence is more common. The most common rhabdomyosarcoma is embryonal, which we used to call it. Now it's fusion negative. Alveolar, much more commonly fusion positive. But as you can see down on the alveolar column, up to 20% of these patients in the genetic portion, up to 20% of traditional alveolar histology are now classified as fusion negative. And also to highlight the genetics, where there's kind of most of the research in these patients, 80% of the embryonal patients have the loss of heterozygosity at 11p15, and they're more commonly, this classification is associated with genetic syndromes like Li-Fraumeni syndrome, neurofibromatosis, and several others. Typically, the location is more favorable locations like head and neck, nasal, periorbital, bladder, and prostate, as compared to the alveolar, which is trunk and extremities, and the inferior orbit. And this is more aggressive, usually older patients. And the classic thing is this fusion positive or negativity that I talked about. 60% of the patients have the PAX3 FOX, which is forkhead box 01 fusion, gene rearrangement or fusion. And then 20% of patients have a different FOX partner, which is PAX7 for that fusion. And like I said, 20% are fusion negative, which is important because the fusion negativity actually in these tumors, they act more like the classic embryonal tumors and are more favorable. And then one we don't see in the third column is the pleomorphic, which is typically in adulthood and is very aggressive. And then the last one, spindle cell sclerosing, is seen in children, but it's kind of fairly newly classified, and there's a lot of things we don't know about that specific subtype. So kind of more into just like a summary slide and kind of what these look like. So small round blue cells under the microscope histologically. The old term, like then, back we used to call it embryonal rhabdomyosarcoma, typically 60 to 70% of the cases. And this resembles immature muscle, so it looks a little more like muscle versus alveolar, which looks more like pulmonary alveoli under the microscope. And the ERMS is associated typically with younger age, favorable site, localized disease, and more favorable prognosis. The spindle cell, it's a much smaller percentage of patients, often seen in pediatrics now as well, and typically a fairly favorable prognosis, except for one specific genetic subtype, which I'll talk about in a little bit. And then onto the traditional alveolar, which now we're calling fusion positive, as I mentioned. to have this old alveolar diagnostic classification, you have to have greater than 50 of the tumor, 50% of the tumor showing this alveolar pattern. And I talked about those fusion, the fusion, what makes it fusion positive, and more commonly extremity, trunk, a lot of lymph node involvement, bone and bone marrow involvement, and portrays a unfavorable prognosis typically. Okay, so this is a patient of mine. Got called by pediatrician in Lafayette. Your mom came into the clinic freaking out. There's a mass. There's something coming out of my baby. This is a 20-month-old patient. There's a visible mass coming out of her vagina. What's going on? There's some blood in her diaper. I'm really concerned. So this is a subtype of the classical embryonal rhabdomyosarcoma called sarcoma botryoides, which translates to a sack of grapes, which we learned in med school, and you kind of visualize how that does look like that. And this is her cross-section of her MRI. And this is usually in a 20-month-old, you don't see the vaginal canal like this, but this is all tumor. Sorry, you can kind of see like the sac-like, like down there, you can see kind of the septations, and it's a pretty interesting phenomenon there with this type. Okay, talking about that PAX fusion, this is just a little cartoon about how the PAX3, there's this break point where PAX3 are down at the bottom, PAX7 kind of splits and then rearranges with the Fox chromosome, part of the chromosome 13, and then there's the activation of this new molecule leading to this fusion that kind of drives the pathogenicity of this of the alveolar or of the fusion positive disease. There's a lot of other genomic alterations. So TP53 mutation is seen in about 10 to 15% of fusion negative rhabdomyosarcoma. It's associated with anaplasia and a decreased event-free survival. So a more aggressive fusion negative subtype. The next one, the MyoD1, it's also seen in fusion-negative rhabdomyosarcoma, often the sclerosing and spindle cell. And this is the one subtype in that category that there's a increased risk of local and distant failure if you have that genetic alteration. And also, interestingly, Dicer1 mutations are more common with historic embryonal rhabdomyosarcoma, and is often seen in the female GU tract and older patients, often involving the cervix and our AYA population. And then kind of the newer genomics, looking at on the right side is it's kind of hard to see there, but there's a lot of NRAS, or there's a lot of RAS pathway mutation seen in fusion negative rhabdomyosarcoma, and that's a lot of the targets that are being looked at currently. Unfortunately, in the fusion positive, you do have the fusion positivity that I mentioned, but there's a lot less other concomitant genetic alterations that offer targetable mutations. And unfortunately, there's not any drugs at the current time to address the fusion positivity with the PAX-Fox fusion. One other hot topic is circulating tumor DNA in a lot of different solid tumors. So patients with fusion-negative rhabdo with detectable circulating DNA at diagnosis has significantly worse outcomes. So you can test blood DNA if biopsy is difficult. The fusion-positive rhabdo, the same, had a much worse outcomes than without the circulating tumor DNA. But because of much smaller patients in this analysis, they concluded that the fusion positive rhabdomyosarcoma, there wasn't enough power there to say that it was independently associated with poor prognosis, the circulating tumor DNA. But there's definitely a hint towards that, even though the p-values weren't significant for fusion-positive rhabdo. Okay, more about the location. This is an older study, but still, the percentages are similar. Current day. So head and neck is the most common, with GU being close in that regard for the frequency of presentation. Of the head and neck, so the really difficult ones is the perimeningeal tumors, which I'll talk a little bit more about a patient case coming up. GU, so bladder, prostate, typically poor prognosis. About half of the GU patients, the bladder and prostate are involved. Paratesticular, vaginal, and uterus, about half of those. And about 20% of all comers involve the extremity, and then there's a broad category of other, which most organ systems have been reported to be involved with rhabdomyosarcoma in patient cases. And I already mentioned the patterns of spread, except for the CNS extension with the perimeningeal, which makes these patients very difficult to treat, like mine. So this is a patient, she's a 21-year-old who came in with very impressive proptosis, complete ptosis of the eye, acute visual changes. We ended up doing emergent radiation because of concern about vision loss. Thankfully, she did not lose vision, but as you can see on the kind of images below, there's a lot of intracranial extension of the tumor, and then later on, she ended up even after radiation to the local radiation and neoadjuvant chemotherapy, ended up progressing with meningeal spread pretty quickly in her treatment, and was very aggressive. And this was a fusion positive alveolar patient. So very tough case, but these perimeningeal tumors are very aggressive typically and difficult to treat. So there are staging and clinical groups, which this is definitely kind of confusing, to say the least. Sorry, trying to blow that up here. So staging. So the staging is like pre-surgery, so clinical staging, and then on the left and then on the right is the grouping, so post-surgical grouping system. We use COG studies use a combination of both, so stage one, this is your favorable sites that can have the tumor size of A or B. A being greater than 5 centimeters. A being less than 5 centimeters, and B being greater than 5 centimeters. And then nodal involvement. This is clinical assessment, so this is based on imaging. So less than 1 centimeter, and the short axis would be negative nodal disease. N1 is greater than 1 centimeter, and then NX is not evaluable. And then, of course, M is metastasis. So stage 2, unfavorable sites, and typically a smaller, not greater than 5 centimeters. And this, I always have to look at it and really look at them. It's definitely confusing. But so, and then, no nodal involvement, then stage 3 is separated between the size less than 5 and greater than 5, and whether or not there's nodal involvement. And stage 4 is metastatic disease, so you can have any site and any size, and that's metastatic. And then onto the grouping. I'm not going to go through all this, but so this is the surgical grouping. So post, not pulling up more there. But so stage 1, that's about 15%. Group 1 is about 15%. That's complete resection. There we go. And localized disease, completely resected, and no regional nodes involved. The group 2 is about 15% as well, so localized but grossly resected with residual disease. And then there's an ABC criteria that I'm not going to completely go through. And group 3 is the largest majority, about 50%. And you can have localized or regional disease, biopsy only, which is a lot of our patients due to morbidity associated with upfront resection, often functional impairment if they did have a upfront resection. So a lot of times we just get a biopsy. And then, there's gross residual disease, obviously, and then about 20% are your distant metastatic disease presentation at onset. And as with that, that's the highest risk disease we see. Let's see. Okay. All right, so next I'm going to talk about the risk stratification. So you bring all those together. This is, according to the National Cancer Institute, risk stratification for rhabdo. So this is kind of new, a very low risk criteria where if you're involving fusion, we used to not, in risk stratification, we used to not involve the fusion status, but now that's used for risk stratification. So fusion negative, and also the MYO1 negative and TP53 wild type. So that can be stage 1, group 1, that's very low risk. And then the low risk is fusion negative, and the wild type for both of those, and stage 1, but group 2 and 3 with orbit only in 3 being low risk. Then kind of as you go down, we have intermediate risk, which is the biggest category. So these can be fusion negative or fusion positive. Only the fusion positive one can be stage 1, 2, or 3, or group 1, 2, and 3. So very clear cut, I know. But used to be also in the intermediate risk category on your fusion negative. Stage 4, group 4 typically were classified as high risk, but now they're intermediate risk because they respond more like your classic fusion negative or embryonal tumors. Even though they're metastatic at diagnosis. And then your high risk or your fusion positive classically, and also your fusion negative, group 4, stage 4, that are greater than 10 years of age. The one in the intermediate risk I didn't mention is if you're less than 10 years of age is more favorable. Okay, so epidemiology and outcome based on the incidence. So intermediate risk, as mentioned, is about 50 to 60% of patients. Then low risk, a little bit less, or almost 30%. Then high risk is thankfully is only 15%. And then this the chart on the right just kind of shows you that fusion positive, even in the same risk category, fusion positivity leads to worse outcomes. Actually, I'm going to skip past this. This is a little bit older data, but kind of the summary is that low and intermediate risk categories were typically pretty good at treating, but the high risk are very poor EFS and overall survival. And then prognosis by location, I mentioned before, orbit, head and neck. Non-perimeningeal is typically thought to be the most favorable site, followed by GU, non-bladder, and non-prostate, then bladder, prostate, then perimeningeal, then other, and then extremity being the worst prognosis. So on to treatment. So it truly is a multimodal treatment strategy where so local control is the initial goal if you can, especially in localized disease. Surgery, so there's different kind of European groups. More aggressive surgery often is used up front, but like I mentioned, you want to limit cosmetic and functional effect. So often times biopsy is the initial how we get our pathologic diagnosis. And then lymph node resection particularly is important in extremity and peritesticular disease. Radiation, these are radiosensitive tumors. So group 1, embryonal or fusion negative, stage 1, group 1 do not receive radiation. The radiation can vary from 36 to 59.4 gray, depending on which stage and group and the degree of resection. Pretreatment size is your so the volume, the radiation volume is typically based on the pre-treatment size before chemo. And then timing varies by protocol. Usually it's about around week 12 to 13 is when we do radiation after the neoadjuvant chemo regimen. And then metastasis, or we do radiate metastasis later than that. And brachytherapy, interestingly, for the 2-year-old, she went to New York, Sloan Kettering, and got localized brachytherapy that worked really well for her radiation, just little inserts of radiation into the vaginal canal, because traditional IMRT would have been difficult and likely cause a lot of functional issues. And then chemotherapy, so for local and systemic control. I'm going to skip past this. This just kind of goes over the dosing, just in sake of time. It goes over the different types of dosing in the different groups. So chemotherapy. So for the low risk, so chemo is used for all of these patients except for the stage 1 group. They get chemo as well. They just don't get radiation. So low risk group, intermediate risk, and high risk. So low risk, there's been multiple studies leading up to, COG and European studies trying to limit the alkylator dosing. So the typical regimen is VAC, which is vincristine, dactinomycin, cyclophosphamide, times 4 cycles, radiation, and then VA, which eliminates the cyclophosphamide, times 4 cycles. So typically about 24 weeks of therapy. And the benefit of that is, like I said, decreasing the overall cyclophosphamide dose. So that's kind of the gold standard there. And then intermediate risk, rhabdo. So VAC was previously standard of care, but we're kind of deviated to a different approach. Europe, they use ifosfamide over cyclophosphamide. Intermediate risk is tricky because 25% of the fusion negative patients relapse, and 50% of fusion positive will relapse. But if good local control and other factors, the 3-year event-free survival is a wide range, but 50 to 75%. And the ARST 0531 study looked at VAC versus VAC-VI, and they both had a similar EFS and overall survival, but VAC-VI was less hematologic toxicity, less febrile neutropenia admissions, and also a lower cyclophosphamide dose, which could lead to less infertility, and also possibly less secondary malignancies. So that was adopted as the newer backbone for our most recent intermediate risk study, which is ARST 1431. So a little bit about that. So that looked at VAC-VI versus VAC-VI plus temsirolimus, which was a newer agent. Well, not new, but it's an mTOR inhibitor that showed activity in relapse rhabdo, and there was some promise and hope that this would really improve the EFS and overall survival for intermediate risk RMS, but the preliminary report shows that there was no improved EFS overall survival with the addition of temsirolimus. The other kind of novel new therapy or new addition was the maintenance therapy, which was shown in patients with similar profiles in a European study. They're adding maintenance versus no maintenance. There was improved overall survival in those patients. So we're still waiting on the final data from this study, but to see the outcome with adding maintenance therapy in intermediate risk rhabdomyosarcoma. High risk is the one where there hasn't been a lot of improvement over time. There's been a lot of different strategies. So, trying interval compressed VAC, which is every 2 weeks instead of every 3 weeks, plus lots of other agents. This is just a few, ifosfamide, etoposide, doxo, and other kind of novel agents. Nothing's really pushed the needle in high risk rhabdomyosarcoma, except the patients that I mentioned, less than 10, they responded well to intensification of therapy, and since then they've been moved to the intermediate risk category. But overall, the 3-year event-free survival is less than 30% for high-risk rhabdo. The most recent study, which one of my patients was on, is looking at vinorelbine along with dactinomycin and cyclophosphamide versus VAC plus maintenance. And vinorelbine was shown to show improved activity in relapsed rhabdomyosarcoma. So that's kind of why looking at that new backbone, substituting vinorelbine with vincristine. And is currently enrolling. And the maintenance, also looking at maintenance in high-risk disease. We don't know if there's a role there, but there was improved survival if you can get in a CR in higher-risk patients in previous studies. So that's also part of the study question, is the maintenance, using maintenance. And then now the newer version of rhabdomyosarcoma studies for COG are just using FOX1, no longer using alveolar versus embryonal. So fusion status is what determines eligibility for these high-risk studies. And relapse rhabdo, as we can predict, is a very poor prognosis, 5-year overall survival, less than 20%, except if you initially have low-risk disease, that survival is better because you can give them more cyclophosphamide and other therapies that they did not receive initially. Also, there's a meta-analysis by Alan Rhodes that relapsed alveolar or fusion-positive rhabdo had better response to vinorelbine alone or in combination. So that's why it's been introduced in the recent COG study. And I mentioned temsirolimus was effective in 0921 for relapse, but doesn't look to be as effective in intermediate risk like we were hoping. This is a bunch of current trials for relapsed rhabdo. Not going to go through all these, obviously, but looking at a lot of different molecular targeted agents, plus CAR T cells, which is hot in a lot of different oncologic conditions now, immunotherapy, and also transplant hasn't shown much benefit in high-risk rhabdo, but I'm hoping somebody can develop a treatment for the fusion positive. Would be great, and that would kind of change things. But there's a big working group trying to advance these because there hasn't been a whole lot of improvement in high-risk disease. So that ends my presentation. Thanks for attending. Sorry about the technical difficulties initially. And I'd like to open the floor to questions.